So we wondered whether we can actually now use NY-ESO-1 as a vaccine strategy, as a vaccine approach to induce T cells so that these NY-ESO-1 specific T cells can mediate destruction of ovarian cancer cells. We did a number of preclinical experiments to prove this, and then we went on to clinical trials of vaccination. So here's just a listing of several trials over the past 10 to 15 years. I'm not going to go into details except to highlight that we use different approaches using peptides designed, peptides derived from NY-ESO-1. We've used the protein, we've used recombinant viruses. In these two examples, this is a recombinant vaccinia virus that expresses NY-ESO-1 as prime, recombinant fowlpox virus that expresses NY-ESO-1 as boost. We've done canary pox virus and so many other strategies. I'm just going to summarize the results of a small phase 2 trial in patients who complete their frontline therapy consisting of surgery and adjuvant chemotherapy, and we're asking the question, can we prolong survival in these patients? A very small phase 2 trial of a prime boost strategy using the recombinant vaccinia and fowlpox expressing NY-ESO-1 to vaccinate ovarian cancer patients. So here's the protocol schema, whereby you get the prime day 1 and then 6 additional injections of boosting with the fowlpox virus. So the first thing that we noticed was that we were able to induce immune responses, both antibody CD8 and CD4 T cell responses in the majority of these patients. I'm not going to get into the details of the results, but importantly, patients who mount a good immune response consisting of antibody, CD8 and CD4 T cell responses are the ones that did the best in this very small study, the patients along this red line. So again, you can see that compared with, again, this was a very small study, but if you compare with the outcome from the GOG protocol 182, where patients got all those different types of combinations, this overall survival in those studies, in that particular study was in fact only 40 months, suggesting that chemotherapy and immunotherapy might work in different ways. Whereas chemotherapy will do something like this, whereby you have shrinking of tumor, but then the tumor grows back. Immunotherapy, on the other hand, will do something like this, whereby there is gradual, prolonged control of the tumor, and the patient does not progress for a very long time. So while those results are very encouraging, we found that ultimately the majority of patients relapse, go on to progress, they progress, and many of them actually succumb to the disease. So the question is, what are the mechanisms by which ovarian cancers escape from immune attack? Because even when you induce immune responses, it doesn't mean that the disease is being controlled. So we and others have identified a number of different mechanisms, and some of them are listed here, and these are all already published. There are a population of cells called regulatory T cells. Sometimes the tumor can downregulate antigen expression. So the expression of the NY-ESO-1 when the tumor relapses is gone. And then a number of other mechanisms, including the role of an enzyme called IDO. I think there was brief mention about PD1, PD-L1 axis, and so on and so forth. So we have focused on these mechanisms, trying to understand them in the laboratory so that we can design additional clinical trials to enhance the efficacy of immunotherapy. Here's an example whereby we looked at the PD-1 axis in ovarian cancer patients. So what we found is that in the majority of ovarian cancer patients, I want you to just focus on the bottom half here, you find that PD-1, which is programmed S1, it's responsible for exhaustion of T cells. The T cells usually are hypofunctional. They are not able to make critical cytokines that are important for killing tumor targets. As you travel from the peripheral blood to the tumor microenvironment, what you find is that the T cells that are infiltrating the tumor begin to acquire PD-1 expression. And when they get to the tumor site, they encounter the ligand PD-L1 that then causes the T cells not to be able to mediate their function. We did some experiments whereby we tested blocking PD-1 in the ovarian tumor-infiltrating T cells, as well as another related molecule called LAG3. And all this slide is showing is that when we block these two pathways, this row here, we can restore the functional activity of the T cells that are infiltrating ovarian tumors, suggesting that this might be a useful approach in the future for treating these patients. In order to further study this, we began to generate animal models, and here we actually were able to knock down both PD-1 and LAG3 to generate mice models to test our hypothesis. When we inject mice with ovarian cancer cells,